Good afternoon, everybody, and welcome to our 12:10 Central Time session. Don't wait for too late. MIGS Beyond Cataract Surgery. My name is Dr. Nate Lighthizer, a faculty member at the Oklahoma College of Optometry, Northeastern State University, or the NSU Oklahoma College of Optometry in Tahlequah, Oklahoma. I want to thank the entire Eyes On Glaucoma team and the Eyes On team for inviting me to do this. And a very special thanks to Sight Sciences for their support of this meeting, their support of this lecture, their support in eye care in general from both the optometry side and the ophthalmology side as well. They've been a tremendous partner, I know, both for this meeting as well as eye care, patient care, and education in general. So thank you for Sight Sciences for supporting this meeting and for this lecture as well. So don't wait for too late. MIGS Beyond Cataract Surgery. We're going to talk about, and we just talked about SLT if you were at my lecture a couple hours ago, on really another treatment option, a procedure that can be done to maybe to reduce IOP, no doubt about it, and lessen the burden of medications for certain patients. Not all patients do well on all of the different medications that we have, and it's tremendous medications that we have in 2021, but there's various intricacies and nuances in patient care where this patient or that patient may not be doing totally great with eye drops and may need some sort of different procedure to best manage their IOP and best manage their glaucoma. So that's where we're going to start with this lecture. Don't wait for too late. MIGS Beyond Cataract Surgery. So I'm guessing everybody on this call agrees that traditionally speaking, when I say traditionally speaking, I really mean over the last 50 years, through the 70s, 80s, 90s, and early 2000s, this was generally speaking the glaucoma treatment paradigm. It was drop first, drop second, drop third. You maximized medical therapy, whether that was one drop, but more often it was on 2 drops or 3 drops or even 4 drops. We maxed out meds. Then we considered laser, ALT historically through the 70s, 80s, 90s, early 2000s. Then we did laser, and then we went to surgery. So it was drops first, laser second, surgery third. That's been the traditional historic paradigm, again, across the decades over the last 4 or 5 decades. This is evolving. This is changing. Again, whether it's SLT, which we talked about 2 years ago, or specifically MIGS, minimally invasive glaucoma procedures, which really have minimally invasive glaucoma surgery, which has really just exploded over the course of the last decade, since 2009, when Dr. Ike Ahmed coined the term MIGS, and it was further defined by AGS and the FDA in 2014. The growth of MIGS over the last 5 to 10 years has been phenomenal and amazing to see. What are MIGS? It's the implantation of a surgical device intended to lower IOP via outflow mechanisms with either an ab internal or ab external approach associated with very little or no scleral dissection. Again, the name really is a beautifully termed name, minimally invasive glaucoma surgery, or MIGS. And new news in 2021, Omni by Sight Sciences has now received an indication to reduce IOP in open-angle glaucoma, which is very good news and a big thing for our patient care. It's a fast-growing, huge-growing segment in ophthalmic surgery, and it's expected to grow over the course of the next, again, decade. From 2017 to 2022, you can see the compound annual growth rate. We know MIGS are here to stay. They've exploded already in the last 5 to 10 years, and that certainly is going to even be more so over the course of the next 5 to 10 years as well. So what are MIGS? MIGS are minimally invasive procedures. Again, we defined this already, little to no scleral dissection, but I think it's just as important to define what are MIGS not. And we have some perceptions by a lot of doctors. I'm probably guilty of this myself over the course of the last 5 to 10 years of, oh, MIGS are this. They're during cataract surgery, and it's surgery, so we should wait until advanced stages of glaucoma. That is, we know, not true anymore. MIGS are not necessarily a stent, and they're not limited to the time of cataract surgery. They can be performed as a solo procedure. So if your patient has already had cataract surgery, we really want to go beyond that. Okay, they've had cataract surgery, MIGS are not an option. That is no longer true in 2021, as they are still a good candidate for a MIGS procedure. We'll present the data from the Romeo studies in just a few minutes, but just because your patient has had cataract surgery does not mean that MIGS can no longer be considered. So they're not necessarily limited to the time of cataract surgery, and they're not necessarily reserved for severe disease. Again, along the lines of SLT, as we just talked about. We want to utilize these procedures that may make it more convenient for the patient in terms of compliance with their therapy earlier in the course of therapy. Why wait until moderate to advanced disease? Maybe mild to moderate disease would be more beneficial for your patient as well. So MIGS are not just necessarily a stent. They're not necessarily limited to time of cataract surgery, and they're not necessarily reserved for severe disease. I think it's important to define what MIGS are, but just as importantly, what MIGS are not in 2021. So why MIGS? You know, if you attended my lecture just a couple of hours ago, I played this video, so you may have seen this already, but I think this is a good option or a good video to show.
They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Now, obviously, that's a TV show. It's House. It's not even dealing in the eye care space. You know, it's with asthma, things like that. But it shows that even the best of intention patients that, yes, I'm taking my medications as prescribed, as I'm supposed to do, I'm taking, and why is it not working? Well, maybe you're not using the medication exactly like it's intended. And again, it's a TV show, it's House, it's not even the eye care space. So does this pertain to us? Well, they've looked at this in the past. There's been studies that have looked on this that have said patient A or patient B or patient C. In these studies, show me how you take your glaucoma medications. And it's been striking.
That's too much.
I think for many of us, our jaw would drop if we had every single glaucoma patient demonstrate, show me how you get your medication in your eye. Again, this is a study by Dr. Robin. You can see in there, Robin, you can see at the bottom there. I want to thank my good friend and colleague, Dr. Justin Schweitzer, for passing along these videos to me. But, you know, it shows that a lot of patients, even with the best of intentions, are not overly compliant and not getting the medication where it needs to be on their ocular surface to treat their glaucoma there. And again, they've looked at these, and even the best of meds that we have, the prostaglandins, 18, 24 months later, we've only got about a 30% compliance rate with the best of meds that are once a day at nighttime before they go to bed. Great side effect profile from a systemic perspective and from an ocular perspective as well. You know, we know patients struggle. I told this study or this story on the lecture from 2 hours ago, but if you weren't on that, you know, I was on the way to Seco actually a couple of months ago. I was in the Uber, the cab, to get from the airport to the convention center, my hotel, as I was starting my meeting. And the Uber driver asked, you know, what do you do? And you always hesitate to kind of, should I ask him or should I answer that question? Because then I'm going to get a bunch of questions about eye care. I said, I'm an eye doctor. And he's told me I was diagnosed with glaucoma a couple of years ago. I'm prescribed eye drops. I don't really take my eye drops, but I have glaucoma. And it was interesting. I didn't ask him if he took his eye drops. He readily volunteered that, yeah, I don't take my eye drops as I should. And it just was ironic as I'm on my way to an eye care meeting. And I think it shows what a lot of patients struggle with in terms of compliance, cost, convenience, et cetera, et cetera. So, you know, why do we utilize lasers, MIGS, these interventional procedures in glaucoma? There's a lot of different reasons. I think historically, one of the biggest reasons that we went to lasers or MIGS was glaucoma was progressing in a patient. They've been on drop 1, they've been on drop 2, maybe even drop 3, and now it's time for something else. Glaucoma was progressing in a patient on maximum medical therapy. But again, I think that's a semi-outdated way to look at when should we utilize laser, or in this case, MIGS, compliance issues, cost issues, convenience issues. I've seen this firsthand with my father-in-law. My wife's dad has glaucoma. He's got a family history of glaucoma. My wife's grandma, my father-in-law's mom, has glaucoma. So there's a family history. And my father-in-law came down to Oklahoma in 2011 for an eye exam. I had just finished residency, or was a year or two out of residency, and he comes down for an eye exam. And we know he's got the family history of glaucoma. Check his pressures, and they're 28 in the right eye and 26 in the left eye. That catches your attention to be in the high 20s. We did a dilated exam, visual field, OCT, ganglion cell analysis. It was obvious that he had glaucoma, moderate to advanced in the right eye and mild to moderate in the left eye. Visual field, based on the visual field staging of the severity of the glaucoma. And I told him, I said, Ken, it's obvious you have glaucoma. There's no doubt about it. You have what your mom has, and we need to initiate therapy because your eye pressures are much too high at 28 and 26 in both eyes. And he looked at me and he said, Nate, you know, I'm 57 years old. He was 57 years old at the time. This is in 2011. He said, I've never worn contact lenses in my entire life. Never worn contact lenses. I've never really utilized eye drops whatsoever. I'm not going to do well with eye drops. Even remembering to putting them in, struggling to get them into the eyes. He goes, I'm not going to do well with that. So again, we kind of tailored that and took in that knowledge and information. And I did a 360-degree SLT on him on June 1st, 2011. Again, all the way around in both eyes. And it took his pressure from 28 and 26 down to about 19 and 18. So we got right at a 30% reduction in IOP. I wanted a little bit more. I set his target at less than or equal to 16 based on his age, the severity of disease in the right eye, as that's where I wanted the target. So I talked him into a half-time prostaglandin. I said, Ken, I know you think you're going to struggle with compliance and remembering these medications. Take this prostaglandin eye drop every other night, 3 times a week. Now, you wouldn't do that maybe in every patient or the vast majority of patients, but in my father-in-law, I talked him into that. I felt comfortable with that. The combination of a 360-degree SLT and a half-time prostaglandin got his pressure to between 13 and 15 back in 2011, 2012. When you fast forward 5 years, and again, that SLT and the half-time prostaglandin held, and I got 5.5 years of keeping that pressure below my target pressure of less than or equal to 16. Well, in 2016 or 2017, his pressure started to creep up into the high teens, low 20s again over multiple different visits. I went, all right, we're no longer hovering between 13 and 16. We are now hovering between 18, 19, and 21, 22, somewhere in there. I said, Ken, we're probably going to have to either repeat the SLT, we'll add a drop, but guess what? He was nearing cataract surgery time. He was complaining of some glare at night. He was complaining of, his vision wasn't quite as good. So guess what? He got a combination cataract surgery and MIGS procedure, and he's been thrilled. He's been staying on 0 or 1 drops over the last 4 or 5 years, been doing very, very well. So it just goes to show the compliance issues, the convenience issues, quality of life issues, and we didn't even get into cost issues, ocular surface disease, et cetera, with him. And he's doing very, very nicely in the combination cataract surgery and MIGS procedure from about 4.5 years ago at this point. So again, why MIGS? If you break it down really into 2 big things, we want to lower IOP. It's still the main modifiable risk factor that we have in patients with glaucomas, to lower that intraocular pressure. That's number 1. We want to lower intraocular pressure. And also at the same time, just as important, if we can reduce the burden of medication for patients, caregivers, staff, et cetera, et cetera. So why MIGS? Again, we talked about a lot of things on this slide, but you break it down. Can we lower the IOP, and can we reduce any potential burden that the patient has, or the caregiver, the staff, the system, with those medications that they're having there? So I think this is a key slide. When we're talking about that IOP, and it's the main modifiable risk factor that we have. And the Advanced Glaucoma Intervention Study, the AGIS study, long-standing study that's helped guide us in our glaucoma management, has told us that if we can get target pressure less than 18 millimeters of mercury, that limits the progression of glaucoma. I would encourage all of you to set target pressures for your glaucoma patients. And you can set a range. I like to set a range for that, or say I'd like it less than or equal to this. If I had to give you the number one target pressure that I set, it's less than or equal to 18 millimeters of mercury. And it's because of this study. Now, that's got to be customized based on the patient, their disease state. Do they have mild, moderate, severe? What's the visual field look like? What's the OCT look like? What's the ERG? What's their IOP look like? So you're going to look at a lot of different variables. But if I had to give you the most common target pressure that I set, it's less than or equal to 18 millimeters of mercury. Again, sometimes it's lower, sometimes it's higher, not often, but that's a good point for a lot of patients. Progression. We know that each millimeter of mercury matters. 17 is better than 18, 15 is better than 16. Significant worsening of the visual field with each 1 millimeter increase in average intraocular pressure. Bottom line, what is this saying? Every millimeter of mercury counts when it comes to that IOP. So again, the lower that we can get it, the better. It's why I like those target pressures. It's why I often set it somewhere between 16 to 18. But again, don't set just my target's going to be always less than 18. It depends on the individual patient, and you customize that based on all the data that you have. Another thing from the AGES study, on average, there was no change in the visual field for patients whose pressure stayed below 18 millimeters of mercury over 6 years. So I think it's important to remember. That's why most often, again, for my mild to moderate patients, target pressure somewhere between 16 to 18, less than or equal to 18 millimeters of mercury, based on all this data that we just talked about, is a nice point to get in many of your glaucoma patients there. So your mild to moderate MIGS, we've kind of covered this already, but historically speaking, before MIGS, we had the 73-year-old female, newly diagnosed. She's got a mild to moderate visual field defect. And what did we do? Drops first. And if that didn't get the pressure where we needed it to be, maybe it was 18 or under, maybe it was less than that, depends on the case. But if that first drop didn't get there, or we're showing progression, then it was drop number 2. And if that didn't get it there, then it was drop number 3. And if that didn't get it there, maybe we're considering surgery at that point. Again, this is before MIGS. Now that we've got MIGS, I think, and I encourage you guys to think of that 73-year-old female. Oftentimes it's going to be SLT or drops as first-line therapy, lowers IOP, but if it doesn't quite get it where you need to go, or progression is noted, instead of going to drop 2 or drop 3 for every single patient, there are going to be patients where skipping right down to that MIGS procedure, whether it's in combination with cataract surgery, whether it's a solo procedure, is going to be very beneficial for that patient in terms of IOP reduction and lessening the burden of medications as well. In my clinic, I often see compliance tank. Compliance patients really struggle when you go from 1 drop to 2. They can often handle that first drop, but when we go from 1 to 2, or especially from 2 to 3, that's where they struggle. I think the benefit of that, of dropping down, okay, let's consider a MIGS procedure, is very beneficial for these patients there. So when we talk about MIGS, remember the conventional outflow pathway. There are 3 potential points of resistance for these patients. I think we've all been well-versed on other ways to reduce their eye pressure, whether it's aqueous suppressants with beta blockers, CAIs, carbonic anhydrase inhibitors, alpha agonists. We've had a lot of medications that decrease production. We've had our main medications, prostaglandins, that work on uveal scleral outflow. So we've had that kind of at the forefront of our attention for a number of years. But it's important not to forget the conventional outflow pathway. And you can see it on the diagram here. Remember that 80%, the vast majority of outflow, of the drainage from the eye, is via this conventional pathway. And that's how I explain it to patients. Think of your eye like a sink. There's an area where the fluid is produced, and there's an area where the fluid drains in your eye. We are going to work on the drain. And there's different aspects of the drain, but this is 80% of the drain here, the conventional outflow pathway. And when they surveyed surgeons, when they talked to surgeons, surgeons want to address the conventional outflow pathway, as you can see here. It is consisted of the trabecular meshwork, Schlemm's canal, and the collector channel. So there's really 3 points of potential resistance among affecting the conventional outflow pathway. Now, we are all very familiar with the trabecular meshwork. Again, we've all been well educated, well versed on the trabecular meshwork, but it's important to not stop there. So because the TM is 50 to 75% of the resistance may be there, it's the most important, but it's not everything. Up to 50% of resistance may be downstream in Schlemm's canal or those collectors channels. So having something that addresses all 3 points of resistance, the TM, Schlemm's canal, those collector channels can certainly be important in lowering our patient's intraocular pressure. How can this happen? Let's watch a short video that can explain this much better than I can.
As eye increases, permeable tissues can begin flattening against the scleral wall, collapsing Schlemm's canal and closing off distal collector channels. The inner lining juxtacanicular tissue can herniate, causing remnants of the trabecular meshwork to begin collapsing the canal lumen and occlude the collector channel ostia.
So I'm going to play this one more time without the audio. So you can see obviously the trabecular meshwork, and again, 50 to 75% of resistance can happen here, but there are times in many patients where fluid can flow through there and resistance is going to start to happen at the level of Schlemm's canal. You get narrowing of this canal. You can get a weakening or herniation of this inner lining of the wall, and it starts to collapse in. And obviously, as you get a narrowing of that canal, that's going to affect outflow. I'm going to start this again one more time. Again, there's the trabecular meshwork, Schlemm's canal, and Schlemm's canal is connected via ostia or openings into these collector channels where aqueous is going to flow and be absorbed out of the eye. So if these openings to the collector channels are blocked due to this collapsing inward of Schlemm's canal, of the wall of the trabecular meshwork, that certainly can create resistance as well. So the take-home point is resistance happens at really multiple different points: trabecular meshwork, Schlemm's canal, the collector channels, and having something that addresses all 3 is certainly going to be important there. Again, we talked about the drug mechanism of action. I've really hit on this already. Early in the course of our glaucoma treatment, we were more focused on the conventional outflow pathway. That would be pilocarpine that targeted that conventional outflow. That has largely over the last 20 to 30 years went away. I've actually never treated a patient with pilocarpine for glaucoma, being practicing for about 12 years now. But our modern agents, the CAIs, the beta blockers, the alpha agonists, really aqueous suppression. They were decreasing the production of aqueous. And our main eye drops, our main first line eye drops early in the course of therapy were at uveal scleral outflow. So again, I think that was at the front of our mind, and that conventional outflow pathway was maybe on the back burner just a little bit, and it's really been brought to the forefront over the last 5 or 10 years with minimally invasive glaucoma surgery there, and other medications that have come about, like the Rho kinase inhibitors, your rocklitans, your Ropressas, even Vyzulta has a degree of that as well. So again, more on the forefront, that conventional outflow pathway, which brings up the Omni surgical system by Sight Sciences. And really the Omni, this is the Omni surgical device, as you can see here. Obviously, as optometrists, myself and many of you on this call, as optometrists, we are not allowed to use this in any states. But this is our fine ophthalmology colleagues utilize this device, a handheld device with numerous features of this, a lure lock, a priming lock. We've got nice gears, as you can see here. And the purpose of this, as that surgeon is introducing this into the eye, the only thing that's going to go into the eye is the cannula. And in this cannula, you're going to be able to introduce a microcatheter. And the microcatheter, the purpose of this is to dilate Schlemm's canal, apply viscoelastic, which will dilate Schlemm's canal and some of the collector channels as well. But that's going to treat all of those points of resistance that we talked about earlier. Again, whether it's Schlemm's canal, the collector channels as well, in a different type of procedure here. So 2 distinct implant procedures in one device, a canaloplasty and a trabeculotomy. So, and these each are going to address different points of resistance. The canaloplasty in Schlemm's canal and those collector channels, as you'll see in the videos in just a little bit, that it introduces this cannula, this microcatheter, I should say, into the canal, which helps to vasodilate. The viscoelastic helps to vasodilate as well, both Schlemm's canal and the collector channels. That's the canaloplasty, helps to potentially decrease resistance. That's not going to address the trabecular meshwork. So a second part of this procedure, again, 2 distinct implant-free procedures, is the trabeculotomy. where that microcatheter, again, is introduced into Schlemm's canal, and then it's pulled gently through the trabecular meshwork in what's called the trabeculotomy. So these two different implant-free procedures that target three different points of resistance in that outflow pathway. So again, we talked about this already, transluminal canal dilation. I am going to let the videos speak for themselves here in just a second.
Chamber through a clear corneal incision. Once inside the eye, the trabecular meshwork is pierced to create an opening where viscodilation of Schlemm's canal can be performed. With the outflow channels dilated, a titratable trabeculotomy unroofs the trabecular meshwork and alleviates resistance, restoring healthy aqueous outflow. With all three potential points of resistance cleared of obstructions, the conventional outflow pathway can sustain healthy intraocular pressure to preserve the optic nerve and protect vision.
So again, I'm going to play this one more time, just so I'm going to mute it here and just kind of talk through this so you can see the cannula being introduced by the surgeon into the angle of the eye, using the gears and that handheld device to introduce the microcatheter, as that is kind of introduced and snaked through this Schlemm's canal for 180 degrees. So this is the canaloplasty. The canal is dilated, it's viscodilated, and you can see an opening up of Schlemm's canal. You can see an opening up of all the collector channels right here. Again, to decrease resistance through those 2 points in the conventional pathway. The cannula is then used to reintroduce the microcatheter, and this is the trabeculotomy portion where, again, the main point of resistance, let's say 50 to 75%, a trabeculotomy is performed to help basically unroof, as you can see there, that trabecular meshwork, and both points of the procedure, both parts of the procedure have now been performed to reduce the resistance and increase outflow and lower IOP there. So there's the model diagram or the model video, as you can see here. We'll take it one step further and let's watch a real procedure here. And again, this is a procedure performed by an ophthalmologist, as they have got the cannula inside the eye here. And again, introducing the microcatheter into Schlemm's canal. You pierce through the trabecular meshwork and to introduce this microcatheter into Schlemm's canal. And you do this for 180 degrees, or approximately half of the eye. And so right now we have transluminal dilation of Schlemm's canal. The visco is used to help dilate that along with the collector channels. And then the surgeon flips the orientation of the cannula. And now we're doing the other 180 degrees of the canaloplasty. So in this particular video, 360 degrees of a canaloplasty is done. And again, using that microcatheter to viscodilate both Schlemm's canal and the collector channels. And at this point, wrapping up the 360 degrees of that canaloplasty is being done. So part one of the procedure is complete. So we've addressed 2 of the 3 points of resistance at this point. That does leave the trabecular meshwork. And in this particular instance, this surgeon decided to do 180 degrees of a trabeculotomy. So that microcatheter is reintroduced on this second 180 degrees. It is kind of snaked all the way around through Schlemm's canal. And then it's simply a mechanical kind of maneuver or movement of this, as you can see, they remove the goniotomy lens and going through the trabecular meshwork as they remove that microcatheter, and it's going to go through the trabecular meshwork and to decrease the resistance of the trabecular meshwork. There's our trabeculotomy as well. So in this case, this surgeon did 360 degrees of a canaloplasty and 180 degrees of a trabeculotomy in this Omni procedure, and the procedure is complete right there. All right. So again, targeting the anatomy, I think we've covered this already. Just a reminder, as the Omni, as you've seen with the canaloplasty, it's targeting both Schlemm's canal and the distal collector channels. The trabeculotomy, the second portion of the Omni procedure, is targeting the trabecular meshwork, with other types of MIGS devices may not be able to get all three different points fully of resistance at both the TM, Schlemm's canal, and the distal collector channels, as you can see right there. So let's look at some clinical data. The Romeo study, I think this was real world data, retrospective real world data. And I think it was important to point out that this wasn't designed to, let's do this study to show this. This was patients in the trenches, doctors in the trenches that were treating these patients in real world practice. And then after that was all complete, go, hey, let's look at the data here. And it's amazing to see what they found in this real world evidence of a review of combination cataract surgery as well as a solo procedure. So there was 2 different publications, excuse me, that were done in the Romeo study. 1 study, 2 publications. They looked at both standalone Omni, a solo procedure, not in combination with cataract surgery, and they looked at a combination procedure as well, kind of the historic, how we've done it over, 2014, 15, 16, over the last 5 or 10 years. First off, it's been in combo, but they also looked at standalone data, which was very interesting to see. Notice in both parts, the standalone as well as the combination, they broke both of these into 2 identical cohorts. Group 1 was an IOP greater than 18, and group 2 was IOP less than or equal to 18. You remember that AGES study that we talked about earlier where we said 18, it's kind of a special number, that 18, when it comes to glaucoma. So they split both groups into cohorts, greater than 18 millimeters of mercury and less than 18 millimeters of mercury. Let's start with the combination, the kind of the traditional use for MIGS in combination with cataract surgery, and let's see what they found. So this was the Omni procedure, canaloplasty and trabeculotomy ab interno, combined with cataract surgery, 12-month outcomes. And notice the 2 cohorts, greater than 18 and less than 18 millimeters of mercury. And what you'll see, the patients with the higher pressures, when they were at 19, 20, 21, 22, notice of 24 patients, the average baseline IOP in this cohort was 22. 12 months later, after combination cataract surgery and Omni, their pressure was right at 15. That represented a 31% reduction in IOP, as well as a 45% reduction in the number of medications that those patients were using. 1/3 of those patients were on 0 medications 1 year later, and success was at about 80% for these patients. They really defined success in a real world way. Success was, did the patient get a 20% or greater IOP reduction, or is their pressure between 6 and 18, kind of that less than 18 cutoff that we talked about earlier, and they're on the same or fewer number of medications with no additional IOP lowering surgery or laser. So you can see a very clinical, it's how we treat glaucoma success criteria. Bottom line, patients that had a combination procedure that had higher IOP cohorts, they got about a 30% pressure reduction along with a 45% medication reduction. How about the patients that had lower IOP? You'll notice a higher N number. Their baseline IOP was 14. When their pressure is 14, we're not going to get that much lower than that. It got it down by about 3/4 of a point, which represented a 5% pressure reduction. But just as importantly, in this group with lower pressures, a 25% medication reduction, with nearly 50% being medication free 1 year later. Powerful data when you look at this. Again, accomplishes 2 things: lowers IOP depending on their pressure, and also a reduction in medication burden as well. Just a different way to show the data. We've already talked about this already. Again, this is combination cataract surgery and Omni, the higher pressure, greater than 18. So cohort number 1, dropping their pressure from 22 to 15 and reducing their meds by about 45%. Group number 2, which was the lower pressure group, yeah, it did stabilize their pressure, nice stable control, about a 5% reduction, but we're nice and low where we want to be, and we're reducing the medication burden as well in these patients there. So combined cataract surgery, Omni, very effective at both of those important points that we've talked about. Let's look at the second part of this study. 2 different publications. Let's look at the standalone data. Basically a solo procedure. These patients had already had cataract surgery, so now we're going in for just a MIGS procedure in these patients here. So this is pseudophakic standalone. They've already had cataract surgery, and notice the two cohorts exactly the same. We cut them off at IOP 18, greater than 18, less than or equal to 18. And you'll notice the similarity with cohort number 1. Remember what the starting baseline was? It was 22 for the combo cataract surgeries, and they got it to about 15. Here, we're right at 22 and got it to 15.5. Represents a 28% drop in IOP and a 29% reduction in medication burden, with nearly 40% of patients drop-free 1 year after this standalone or solo Omni procedure there. Cohort 2, IOP less than 18. Again, these patients with lower pressures that were about 15. And you remember these got it down to about 14, very similar to the combo cataract Omni. Actually, a little bit better pressure reduction here, lowering it by about 10%. And the medication reduction, 35%, with just about 1/3 of patients being drop-free or medication-free 1 year later. It was amazing to see just how similar the data was between the pseudophakic standalone or solo procedures and the combo. I mean, very, very similar in terms of IOP reduction and medication reduction as well in these patients here. Another way to show it, again, this is the pseudophakic solo procedures. If their IOP was greater than 18, we had about a 30%, 28% reduction in IOP from just under 22 to just about 15.5. And the medication burden was reduced as well, as you can see with that bar chart there. The cohort number 2, again, lower pressure, standalone pseudophakic procedures. Pressure was already 15-ish, got it down to about 14, a 10% reduction, but reducing that medication burden as well, as you can see with the Romeo data. So I thought it was very, very interesting. You go back to kind of the two parts of this, very similar. I thought these mirrored each other very, very nicely, and both say that cataract surgery plus Omni or Omni alone as a solo procedure accomplishes two things in our patients depending on the IOP. If the IOP is a little higher, greater than 18, it's going to reduce the IOP and reduce their medication burden. If their IOP is already well controlled at 14, 15, 16, somewhere in there, it's still going to have a nice benefit of reducing that medication burden, as you can see there. So summary of the Omni surgical system addresses all 3 points of the conventional outflow pathway, as we've talked about, intervening early. Don't wait so long in those glaucoma patients. It's a lesson that I've learned over the years of let's not wait until they have moderate to advanced glaucoma. Mild to moderate, controlling the IOP, reducing the medication burden as a combo with cataract surgery, or now in the last couple of years, especially in 2021, used as a solo procedure as well. So a couple of considerations or clinical pearls really in our last 10 to 15 minutes here. We've talked about the burden of glaucoma, so I'm going to skip by this. We've covered this, I think, in detail already on the quality of life, disease progression, et cetera, et cetera. Patient selection considerations. The low-hanging fruit, the most obvious benefit and most obvious utilization over the course of the last 5 to 10 years is that open-angle glaucoma patient that's on a couple of drops, IOP is increasing, and or progression is noted, and a candidate for cataract surgery. Their vision's blurry, and now they're going to get a combined cataract surgery MIGS, just like my father-in-law. I'm guessing most of you fully recognize the utilization, the need, and the benefit of MIGS to go along with cataract surgery. But the point of this presentation is don't forget about this patient, the pseudophakic PUAG patient that's on 1 drop or 2 drops. Maybe they've already had an SLT. Their visual field is showing signs of progression. Their OCT is showing signs of progression. Maybe the pressure is creeping up as well. In my clinic, when you go from 1 drop to 2, compliance suffers, especially when you go from 2 to 3 drops. So that pseudophakic patient, instead of potentially adding a 2nd drop or a 3rd drop, remember MIGS in this space as a solo procedure and really can have multiple benefits, as we've discussed as well. You know, who else could potentially benefit? Again, patients that are progressing, patients that need lower IOP, patients that want to discontinue or decrease their meds. Have you ever had a glaucoma patient come to you and say, "Doc, I'm tired of my drops. I'm tired of these 2 drops, 3 drops, whatever it is. Maybe it's the adverse events. Maybe it's potential allergies. Maybe they can't afford them or whatever reason, or maybe they're just not compliant." There's a lot of potential benefits as you're talking to and managing these glaucoma patients. Post-op considerations. You know, this is really, to me, diving down into the trenches when you're managing the post-op considerations. We've talked about when the indications are, when do you choose this? Again, compliance, reducing IOP, medication burden, but we also need to be familiar with the post-op considerations. what is the visual acuity impact at day one when you're managing MIGS with cataract surgery, or even solo MIGS or standalone MIGS? To me, in my experience, it's very close or very similar to what the visual acuity will be one day after cataract surgery. Now, do remember that there is a slightly higher risk of hyphema when it comes to MIGS. There's not much of a risk for hyphema for standalone cataract surgery, but when you add in that MIGS procedure with a trabeculotomy or other types of MIGS procedures, when you're cutting through the angle, there certainly is a risk of hyphema, microhyphema. So I would encourage you to get out ahead of that. That say, usually for the majority of patients, visual acuity is very good. However, that if you do have a little bit of bleeding, which is very normal, it's very common during the procedure, don't be alarmed if your visual acuity is down in that 1 day post-op. I've had patients that their vision was less than 20/50 on the 1 day post-op. More often than not, it's good, but under promise and over deliver, just like we do for refractive surgery or other conditions as well. But usually speaking, visual acuity is pretty good on that 1 day post-op, unless they've got a little bit of a hyphema or microhyphema, and you've educated them pre-op that this can happen. It's not concerning. And going down to the last question, usually those red blood cells, that hyphema or microhyphema, it's often significantly resolved by the 1 week and usually gone in the week or two after that. So most of the red blood cells, reflux blood, usually goes away in that first 1 to 3 weeks after the MIGS procedure. How long should the post-op antibiotic be maintained? I maintain that for 1 week. Just like cataract surgery, so very similar to cataract surgery. When is the full IOP reduction typically reached? We don't make any decisions until about 1 to 3 months. And I tell patients that just like with PRK and LASIK, we're not going to consider any other refractive surgery procedures until 6 months, because things can take 2, 3, 4, 5 months to settle out with refractive surgery. Same thing here, but it's 3 months. So 3 months is, we're not going to do anything else at this point in terms of other surgical options, things like that, until we know what your IOP is at that 3-month point. Now, I think we know most of it by 1 month, but there are patients where their pressure may be up a little bit at 1 month and it stabilizes nicely by 3 months. So the question, when is the full IOP reduction typically reached? I feel at about 3 months. That's where we would take that. How should IOP spikes be managed? Same exact way that they would be managed for cataract surgery. If you've got a patient with an IOP spike, it's your beta blockers and your CAIs and your alpha agonists, things like Diamox, if it got particularly severe in that case. So the same way that you manage IOP spikes for cataract surgery would be managed here, obviously always remembering your potential contraindications. How long should the steroid taper be? Steroid taper, same as cataract surgery. I taper this out to 1 month. At that 1 month point, that's when we can, basically get them off the steroid at that point. And when can glaucoma meds be discontinued? My answer is typically about a month is when I will start to consider pulling a medication if we got to the target pressure where we want to be. And again, I want to make that point again of please, I encourage you to set target pressures based on severity of disease, what's the nerve look like, visual field, OCT, etc. Where should their target be? Now, one of my good friends and colleagues and somebody I respect a tremendous amount, Dr. Justin Schweitzer, who has one of the most extensive experiences in managing MIGS. I know I was on the phone with him yesterday, we were chatting, and he said he will consider pulling a med at 1 week in the right patient. I tend to wait till 1 month. But I will only peel 1 medication at a time, meaning I will not peel 2 or 3 medications, but I would peel a med at 1 week. I've done that before, not common. I will do it at a month as well. So 1 medication at a time. I usually start, not always, but usually start at 1 month post-op, but some do start as early as 1 week post-op, depending on what's going on in the anterior chamber, IOP, et cetera there. So set that target IOP. If they are at target IOP, as early as a week, but most definitely at a month, you could start peeling medications 1 at a time if you so desire. We answered the last question already at this point. All right. So setting up for success, certainly communication is key with this. Knowing your surgeon, you guys and I am not doing this procedure, whether it's MIGS, Omni, as we've talked about extensively. So knowing who your referring doctor is, who's the surgeon that you're going to send to, what MIGS procedures are they doing. You can want an Omni done for your patient all day long, but if you send to a surgeon that's not doing that, you're not going to get the procedure. So good communication between the patient, the referring doctor, the surgeon. So we are all on the same page of educating, talking to your patient, letting them know. I explained to them, this is minimally invasive glaucoma surgery. So while it is surgery, right in the name, it's minimally invasive, quick healing, quick recovery time for the vast majority of patients. We talk about the potential post-op complications, but we talk about the procedure, how the post-op is likely going to go, what they're going to hear from the surgeon. More communication, better communication certainly is going to be in the benefit for these patients here. And I think there's a significant unmet need, as we've talked about. Historically speaking, over the last 5 to 10 years, MIGS started out as when surgery is going on, usually cataract surgery. So when cataract surgery was going on, we could do a MIGS procedure as well. But as we go forward over the next 5, 8, 10, 12 years, as this graph shows, they've done market research on this, that this is MIGS with cataract surgery, this piece of the pie right here. And this likely is going to be a much bigger piece of the pie of solo MIGS procedures because they're so efficacious, because they reduce that medication burden, and because they carry a very good safety profile. We're going to have more and more solo MIGS procedures in pseudophakic patients that have already had cataract surgery. So a significant market opportunity, unmet need, I should say, exists in the post-cataract surgery population. So, in conclusion, the 1, 2, 3, we have one great implant-free option for treating a variety of stages of glaucoma, the mild to moderate, and that's the Omni device. Implant-free, and remember, it's not just the severe advanced glaucoma, mild to moderate glaucoma, and two great options to utilize this. And it's not just when they have cataract surgery. I think that's the biggest take-home point from this, is it's more than just when they're ready for cataract surgery. If they're not ready for cataract surgery, or most often, if they've already had cataract surgery. In your pseudophakic patient, great data from the Romeo studies on this works very, very well, lowering pressure 28 to 31% and reducing that medication burden from 30 to 50% as well. So two great times to do this during cataract surgery and as a solo procedure as well. And again, targets 3 points of resistance: the trabecular meshwork with the trabeculotomy, Schlemm's canal, and those distal collector channels with the canaloplasty as well. So again, to sum up in my last really 4 or 5 minutes here, this was the traditional paradigm. As I covered this on the very first slide of this talk, it was drops were first, then we went to laser, then we went to surgery. I really believe in 2021, we have 2 first-line options. As you can see on the left here, and don't confuse the 1 and the 2. This really should say 1 and 1A, or 1A and 1 in any particular order. We've got 2 great first-line options, whether it's SLT, whether it's the medications that we have, whether it's Vyzulta, Rocklatan, the traditional prostaglandins. 2 great first-line options, as you can see here. But then we've got that new category, the minimally invasive glaucoma surgery. That's not way over here on the right. It's not the advanced disease. It's right here in the middle. It could be used in mild. It could be used in moderate. It could be used in its severe as well, but encourage earlier looking at MIGS procedures, the Omni procedure, when they've got mild to moderate glaucoma, when they're on 1 drop, 2 drops, ready for cataract surgery, or as a solo procedure as well. So it's been fun to see how the paradigm has shifted from this traditionally to, I really believe it's now we're looking at this in 2021 there. So with that, I'm down to the last 2 or 3 minutes, and I'm looking in the chat box for some questions here. When is the ideal time to refer for a surgical consult? Yeah, you guys know your patients best. You're seeing the patient, and again, there could be a variety of reasons why you want to refer for a surgical consult. IOP is increasing. They're looking at the IOP, and you know what, shoot, I want the IOP here, and it's above target, and it's above target, and it's above target on multiple different visits. IOP is increasing. They're showing signs of progression on your variety of glaucoma tests. Or maybe the patient says, you know what, I'm tired of drops. I want to get off of drops, or I can no longer handle my 3 drops or my 2 drops, and they want to decrease their medication burden. Maybe they're having adverse events. So we talked about a lot of these reasons of it may be compliance, it may be progression, it may be IOP, it may be doctor initiated, it may be patient initiated, depending on what they tell you as well. What should I look for that would prompt me to refer? Again, I think it's similar to the last question of what should you look for? You should look for any potential signs of progression, any elevated IOP, anything, and listen to the patient. Not necessarily look for, but listen to the patient and what they're telling you. Are you seeing signs on the cornea that maybe is worsening their dry eye? So look and listen to the patient, and they may be telling you, you know what? I've reached my meds that I can handle, or I want to be decreased off of some of those meds as well, and it may be time for a surgical consult at this point. Patients are hesitant when it comes to surgery. My last 30 seconds, how do you educate the patient on the option for MIGS? Again, I tell them, I don't just say we're going to do MIGS because the patient's going to go, what is MIGS? It's minimally invasive glaucoma surgery, and I highlight the M and the I, minimally invasive. They've come about in the last 10 years, and they are tremendous options for our glaucoma patients. They work on the drain of the eye. They carry a very nice efficacious or effectiveness profile and a very nice side effect or potential adverse event profile as well. It doesn't mean you can't have them, and we go through those, but it's minimally invasive. It works on the drain of the eye, and it's been shown to lower your eye pressure, which is what we want to do. And it's been shown to potentially lower your medication burden, maybe decrease you off a drop if that you so desire, or prevent you from going on the next drop. So with that, we have reached the end of our time here. I want to thank everybody for being here. I want to thank again Sight Sciences for their support of this conference. Everybody have a wonderful rest of your conference and a great day. Thanks all.